Hello everyone. In this session, I will describe basic aspects of the pediatric pharmacology. Let us understand the development and growth in children. Pediatric age groups start from newborn up to 28 days. Then there is infant for 12 months, toddler for 2 years, preschool up to 5 years, school age up to 11 years, and then there is adolescent or teenage. Body fluid composition changes as there is a growth and development in children. If you look at this table, we'll find that as weight increases, body fat percentage also increases to some extent, and it is very low in premature newborns, whereas it is much higher up to 1 year. The protein percentage in the body gradually increases till adulthood, and the water content gradually reduces till adulthood. Associated with these changes, there are also changes in the physiological functions as there is a rapid growth and maturation. For example, gastric pH production approximates adulthood by 3 months. Gastric emptying also reaches 6 to 8 months to the adulthood. Phase 1 and phase 2 metabolisms also have developed gradually. For example, phase 1 biotransformation may require 5 months to 5 years to achieve adult levels, whereas phase 2 conjugations are measuring much earlier by 6 months. Drug excretion to adulthood reaches by 1 year of age, depending on the development of kidney function and glomerular filtration. Now, pharmacokinetic factors include changes in the absorption, distribution, metabolism, and fate. Drug absorption, when given drug parenterally, because of smaller muscle mass, the local injection intramuscularly can be painful. Transdermal application of the drug would result in rapid absorption because of increased vascularity and thinness of the skin, whereas the oral absorption depends on several physiological variables. In full-term infants, gastric pH is neutral and acid secretion begins soon after the birth and increases gradually over several hours. And in preterm infants, secretion of gastric acid occurs more slowly. Gastrointestinal enzyme activities also tend to be lower in newborn than in adults. Neonates have lower concentration of bile acids and lipases, that is enzymes. Therefore, it may decrease the absorption of lipid-soluble drugs. Changes in the gastrointestinal motility are also seen. Peristalsis in neonates is irregular and may be slow and becomes regular by the end of 1 year. Gastric emptying depends on the fat content of the milk, and it also depends on the changes in the splenic blood flow. So the intestinal motility and absorption will be dependent on splenic blood flow and the rate of gastric emptying. These two factors increase in children aged 2 to 6. Some of the examples where bioavailability changes have been seen are paracetamol absorption is reduced, ampicillin absorption is increased, diazepam absorption may be normal, and phenobarbital phenytoin absorption is reduced in neonates. Distribution of the drug, particularly volume of distribution, and if we look at this, we will find that neonates have higher percentage of body weight in form of water than does the adult. Extracellular water is 40% of the body weight in neonates as compared to 20% in adults. Therefore, neonates will show diuresis in first 1 to 2 days of the life. Many drugs are distributed throughout the extracellular compartment, that is water, and distribution is mostly determined by the water content, and that results in altered volume of distribution. Now, this is particularly important for the drugs which are highly water soluble. For example, aminoglycosides, and may be less important for lipid soluble agents. Occasionally, a loading dose of drug would be required because larger apparent volume of distribution is obtained in neonates. Protein binding is also altered. Neonates and premature infants have low albumin and lower drug binding abilities of the drugs such as local anesthetics, diazepam, phenytoin, ampicillin, and phenobarbital. Therefore, the concentration of the drug, which is unbound and free in plasma, is increased initially in neonates, and this may actually lead to toxicity if loading doses are given. Drugs given to neonate with hyperbilirubinemia can displace bilirubin from the albumin binding sites, such as sulfonamides, and that may be the reason for occurring of the kernicterus in neonates. Obviously, half-life of the drug is also changed in neonates and premature. Now, looking at the changes in the half-life, we'll find toddlers may have shorter elimination half-lives because compared to older children and adults. This is very important to observe. Because of shorter half-lives, greater doses might have, or frequency might have been given. Now, in general, neonates may show half-life of paracetamol which is roughly double to adults. Similarly, diazepam half-life is roughly double to adults. Digoxin half-life is also roughly double to adults, whereas phenytoin half-life is also increased more than double. Phenobarbital half-life is increased. Salicylate half-life is mostly unchanged, and theophylline half-life is also increased. Therefore, drugs whose half-lives are increased have to be given at a lesser dose in neonates as compared to toddlers. Drug metabolism, drug metabolizing ability of cytochrome system and conjugating enzymes are substantially lower in neonatal life compared to adults, and therefore rate of metabolism varies. Phase 1 metabolism, that includes oxidation, reduction and hydrolysis. Among these, oxidation and demethylation are less developed. Reduction is nearly normal developed, whereas methylation is enhanced in neonates. Different drug metabolites can also be produced because of these changes. For example, 30% theophylline is converted to caffeine in neonates, whereas most of it is converted to uric acid metabolites in adults. Therefore, CNS stimulation may be much more than. Phase 2 conjugations, enzyme activity reaches near adulthood by 3 months as spoken earlier. Glucuronide formation reaches adult values between 3rd and 4th year of life. Immature glucuronization of chloramphenicol causes gray baby syndrome in neonates and infants, and infants and children have greater capacity for sulfate conjugation. Now this point is very important because most of the paracetamol given is sulfated largely, and because it is sulfated largely, less is available for cytochrome 2E1 metabolism to toxic intermediate, and there is also increased glutathione turnover. Now these are the factors that leads to reduced paracetamol hepatotoxicity in children under 6 years of age. However, thereafter hepatotoxicity is likely to occur. Delayed expression of the UGT1A1 gene in newborns is the primary reason for neonatal hyperbilirubinemia because the endogenous bilirubin is not conjugated. Many drugs have slower clearance rates and prolonged elimination half-lives in neonates, requiring changes in the dose and dose intervals. But between 2 and 12 years of age, drug clearance greatly increases and often exceeds adult level. Therefore, half-life of the drugs are shorter and dosing requirements are frequent as compared to adults. One example could be given here is levetiracetam, whose clearance has increased So higher milligram per kg dose is required in patients up to 12 years of age with convulsions. Maternal use of enzyme inducers can also alter the drug metabolism in neonates, particularly premature infants. Phenobarbital intake by mother may induce early maturation of fetal hepatic enzymes in neonates. An ability of neonate to metabolize certain drugs will be greater than expected because of metabolic enzyme induction upon maternal phenobarbital use, and one may see less therapeutic effect and lower plasma concentration for certain drugs. Not for all, but for certain drugs. And this point should also be kept in mind. Likewise, phenobarbital have been given to neonate for enzyme induction to treat neonatal jaundice in some. Drug excretion is also changed in neonates. It also changes in infants and toddlers. The glomerular filtration rate is much lower in newborns than in older infants, children, and adults, and this persists during first few years of life. Calculated on the basis of body surface area, glomerular filtration in neonates is calculated as only 40% of the adult value. However, by 12 months of age, it reaches the adult values. During toddlerhood, up to 2 years, the glomerular filtration rate may exceed adulthood, and therefore those adjustments milligram per kg have to be done as compared to adults. Tubular secretion and reabsorption reaches adult levels by 7 months of the age, and adults' excretory pattern is seen by the end of 1 year of life. These patterns are very important to remember for adequate dose adjustment and avoiding toxicity. Now, some examples of changes in the doses due to increased clearance of drugs. Penicillin dose is given in 2 divided doses 7-day-old infant. However, higher penicillin dose in 3 divided doses may be required in infants over 7 days. Aminoglycoside doses of aminoglycoside for a neonate less than 7 days is 5 mg per kg per day in 2 doses, whereas the dose for 7-day-old and over is 7.5 mg per kg per day in 3 doses. That means 8 hourly. In premature newborn, dose is given once a day only. That means it depends on whether the neonate is premature or infant. Simple rule is that dose interval can be calculated depending on the level of plasma creatinine. If plasma creatinine is doubled, the dose interval is also increased by 2. So it is a simple one. So a factor of 8 is equal to dose interval. Toddlers may have shorter elimination half-lives of the drugs than older children and adults, probably due to increased metabolism and excretion. Digoxin dose is much higher in toddlers than in adults because digoxin clearance is increased. Now, special features for neonates are indomethacin causes rapid closure of patent ductus arteriosus, which would otherwise require surgical closure. Infusion of prostaglandin E1 causes ductus to remain open, which can be life-saving in an infant with transposition of great vessels or tetralogy of Fallot's. Neonates are also more sensitive to central depressant effects of opioids than older children and others. There are reasons for that. Neonates may have poor drug transporter function and low level of the P-glycoprotein that excludes the drug from the cells and maintains adequate blood-brain barrier. It is poor at birth, and that can explain why neonates are substantially more sensitive than older children to depressant effects of CNS depressants, including opioids. Now, some other pharmacodynamic features are preterm babies have immature metabolized enzymes, so exaggerated response to certain drugs is seen because these drugs are not adequately metabolized, antihistaminics, so best avoided. Older children can tolerate digoxin, as already spoken about, and morphine may cause excitation in female babies. Hepatic porphyria may be precipitated by drugs which induce hepatic ALA synthesis, chloroquine, phenobarbital, hydantoin, alpha-methyl-dopa, and drugs can induce hemolysis in glucose 6-phosphate dehydrogenase deficiency. So drugs like probenecid, sulfonamide, primaquine, antimalarials should be avoided. Specific adverse drug reactions may be seen in children than in adults. Furosemide may cause nephrocalcinosis. Indomethacin may cause renal failure or bowel perforation. Glucocorticoids are known to delay linear growth. Phenobarbital may cause hyperactivity, impaired intellectual development. Tetracycline in children may cause discoloration of teeth. Phenytoin may cause coarse features and thickened skull. Chloramphenicol is not used nowadays. It has caused gray baby syndrome. Phenothiazines may cause dystonic reaction sedation. Valproic acid hepatotoxicity in young children. Aspirin will cause Reye's syndrome when used in influenza, and risperidone delayed sexual maturation in adolescents. So these specific features must be kept in. Children with protein energy malnutrition are especially prone to ADRs or differential pharmacodynamic and kinetic effects, and they require polytherapy. A number of drugs are given because of intercurrent infections and their nutritional needs. Malnutrition, by changing proteins, alters pharmacokinetics of the drugs, and it makes them vulnerable to ADR. They are more sensitive to digoxin, so the dose must be reduced. Chloroquine is bound more to plasma protein in kwashiorkor, so less is available free for antimalarial action. Hypoproteinemia increases free drug concentration, so if loading doses are given, toxicity may be seen. Drug clearance is reduced, thus dose calculation need to be done according to body weight, but lean body mass may be taken on an average. Actual body weight dose calculation as per actual body weight in malnourished child may be erratic. Better calculate doses in malnourished child by body surface area method. Oral medication, few guidelines, instructions. Drops and syrups should be palatable for proper intake. Children can take mouth dissolving or dispersible tablets. Capsule can be avoided. Phenytoin suspension should be shaken well, otherwise the last doses will cause higher concentration toxicity. Medicine should not be placed on dorsum of tongue, but placed on the sides of the tongue and between tongue and cheek. Medicine should not be mixed with milk because it may make it unpalatable, so neither medicine nor milk goes to the child. A non-bitter tablet can be crushed and mixed with honey or fruit juice. Vomiting may occur in toddlers. Diversion of attention and re-administration of dose if vomiting occurs after 5 to 10 minutes should be done. Drugs are better absorbed when given on empty stomach or 2 after meals, that is in between feeding. Some drugs must be given on empty stomach. They are well known: levothyroxine, ampicillin, azithromycin, rifampicin, didenosine, digoxin, omeprazole, ranitidine, and methotrexate. Children and adolescents have higher volume of the body water and higher estimated GFR than adults. So it results in shorter half-life of lithium, and that is very important for those children who are young infants or children who are receiving lithium carbonate. First generation antihistaminics are not recommended for use in children because they are sedating and they may cause learning impairment and poor school performance. Use of OTC cough and cold formula, most of them contains antihistamines, decongestants, sympathomimetics combinations, and young children less than 2 years is not recommended because they are associated with a variety of serious side effects and deaths have been reported. Second generation antihistaminics, of which cetirizine is well studied, can be given in adequate doses. Children with cystic fibrosis have increased hepatic metabolism and therefore increased drug clearance. Appropriate dose increments must be done. Regular measurement of weight in children is very important because they are in the growing age. So their weight gain may result in low blood levels of the drugs. Therefore, adequate dose adjustments are required, particularly for anti-tubercular drugs. Dose calculation in children. The most reliable pediatric dose information is usually available with the product package insert and that should be consulted. When it is not available, then approximate dose calculations can be done by various formula. These calculations are based on age, weight or surface area. Now, in general, drugs with wide safety margin, approved drugs can be given as milligram per kg basis with specific information on pediatric dosing. Avoid fixed dose combinations because there will be difficulty in calculation of dose of each component. Several dose calculation formula are available. Young's formula, Clark's formula, or a simple is dose is equal to adult dose weight divided by 70. So that is the simplest formula, Clark's rule. Surface area formula is surface area of the child divided by 1.73 or 1.8 into adult dose. Freeze formula is for infants, age in months upon 150 adult dose. In obese children, they have higher fat mass, slower drug metabolic rates and reduced clearance of drugs. It is recommended to calculate doses on the basis of ideal body weight for that age. So lean body mass should be taken so that excess of fat is ignored. Studies indicate that dosing based on per kilogram body weight may constitute overdosing in obese children. Surface area formula and tables are available and it will be prudent to use them whenever there is difficulty. For example, 1 year child weighing 10 kg would have approximate half of the body surface area of the adult. Therefore, dose would be 28% of the adult dose. This has been calculated in formula according to formula and tabulated. So, for 5.5 years, 50% of the adult dose would be required. Some drugs need to be given higher than adult milligram per kg doses, particularly isoniazid, because elimination is faster in young children than older ones. Similarly, rifampicin, children may achieve a lower rifampicin blood levels after receiving a standard milligram per kg dose as compared to adults. Other drugs for which some information for higher dose milligram per kg is required are levetiracetam, theophylline, increased clearance, cetirizine, and gentamicin. Pediatric adherence to therapy is one of the most important tasks for a practicing pediatrician, and it is really difficult because parents have to be involved. Parents' conscientious effort is needed. Measuring errors, spitting, they all occur with child dosing. Measured volume of teaspoons is full of pheresis and it may vary from 2.5 ml to 7.8 ml. It is better to use a calibrated spoon or measuring cap or a syringe to accurately measure the drugs with narrow therapeutic margin, and most of them are available as drops or syrups. Parents must be told whether not to wake the child or infant for its every 6-hour dosing at night. Older children may take some responsibility for administering certain drugs. They have understood subcutaneous insulin after consultation with parents. To conclude, we can say children are not small adults, infants are not small children, newborns are not small infants, and premature infants are not small newborns. And this point should always be kept in mind while prescribing for children. Neonates and infants can be considered as a special age group for drug therapy because of the changes in the metabolic disposition and drug sensitivity. Pharmacological responses would vary because there are changes in the pharmacodynamics of the drug or pharmacodynamics of the. So this is all about this pediatric pharmacology. Few questions can be given in this form for assessment. Describe key pharmacokinetic features affecting drug disposition in neonates and children, or it can be in the form of pediatric pharmacokinetics, or it can be pediatric dose calculations. And this is all about